Okay, so hi everyone, my name is Katie and I am one of the physios working alongside Colin in the weight management service here. So I'm going to chat to you today a bit about physical activity and function pre and post bariatric surgery. So carrying on, I suppose, on that note around language and how we choose our words and how important that is. So you'll hear us using physical activity and movement a lot today, as opposed to the word exercise. And again, that's something I'd urge you to kind of consider, as you do approach this topic of conversation with patients. We tend to stay away from the word exercise because of the message it carries, and it can be quite intimidating, and people might think that we're, expecting them to be hopping up on a treadmill or doing hours in the gym, and that's not the message that we are trying to get across. So firstly, we're going to look at what the evidence says about physical activity and function pre-bariatric surgery. So it shows that this population are inactive and sedentary. So this study by Bond et al. Measured objectively physical activity levels prior to surgery, and what it found that 68% of patients did not engage in any bout-related moderate to vigorous physical activity pre-surgery, and around 4.5% accumulated greater than or equal to 150 minutes per week. In the second study, which was a longitudinal assessment of bariatric surgery, they also objectively measured physical activity levels, and they found 20% were sedentary, 34% were low active, and 61% of participants did not engage in any bout-related moderate or vigorous physical activity. So it's worth noting that these studies are kind of quite outdated, and you can see they're focusing on moderate to vigorous physical activity, and again, we know there's growing evidence that moving around at a comfortable, a low to moderate intensity is beneficial, is associated with improved health outcomes and reduced mortality. It's also important to note that it is really tricky to measure activity levels accurately, whether it be subjectively or objectively. It's quite tricky. So it's not the best quality of evidence, but I suppose the main point to take away is that this population are inactive and have low activity levels. So what is the value of physical activity pre-bariatric surgery? So the clinical guidelines recommend increasing physical activity to optimise our surgical outcomes, so to reduce surgical complications and to facilitate healing and post-op recovery. So again, there's kind of limited number of studies in this area, but 3 small studies of pre-op exercise or physical activity have shown positive trends in aerobic capacity with physical activity, along with improved weight and cardiometabolic parameters, quality of life, and also reduced physical activity barriers post-intervention. So I know most of you here today are dietitians, and I think there's a few GP trainees here as well. Discussing physical activity might be something that you are comfortable with, might be something that you're maybe not so confident in discussing this with your patients. And I suppose it's just to highlight the importance of it pre-surgery. We often find post-op patients can be quite overwhelmed. There's a lot going on. They might be that bit more receptive to engaging in a conversation around physical activity and movement pre-surgery. And hopefully, I suppose, identifying barriers before surgery will lead to increased physical activity levels post-op. So looking at the recommendations then, so the American Society for Metabolic and Bariatric Surgery and the American Heart Association advise low to moderate intensity physical activity for at least 20 minutes a day, 3 to 4 days a week prior to surgery. And again, it's nice to see those words low to moderate intensity being used. Again, we're moving away from that idea that exercise or physical activity or movement needs to be hard, but moving around at a comfortable level is beneficial, and that's quite encouraging for our patient population who do experience a lot of difficulties with movement. So you'd be encouraging aerobic exercise along with light resistance training. So then moving on to physical activity levels post-bariatric surgery. So again, physical activity habits haven't been clearly defined or described, but the evidence again shows that they are inactive and sedentary. So studies of self-reported physical activity will consistently report substantial increases between pre and post-op activity levels, but these assessments relied exclusively on self-reported measures through retrospective questionnaires, and again these measures carry high potential for inaccuracies. So that same study by Bond et al, they found that self-reported physical activity levels increased by 500% post-op, but these changes weren't corroborated by objective measures, and in fact there was no significant changes, and it was still around 5% of participants were accumulating that 150 minutes a week of moderate to vigorous physical activity post-op. So other studies have found, again, that activity levels for this population are low relative to recommended levels. I suppose, again, it's not the highest quality evidence, and what we found amongst the patients that we speak to is that physical activity levels will increase for about kind of 60 to 70% of them post-surgery, particularly in the first kind of year and a half, what we call that honeymoon phase, but then normally around that kind of 18 months to 2 years, when problems maybe start to re-emerge, activity levels can start to decline again. And again, it's just highlighting, I suppose, support is beneficial at every stage. And as we heard from our patient experiences, everyone's journey is different. So again, there's currently no evidence-based physical activity guidelines specifically for bariatric surgery, but joint guidelines from the American Society for Metabolic and Bariatric Surgery and the AHA and the Obesity Society advise adhering to a healthy lifestyle, which includes exercising for at least 30 minutes a day. And again, there's that word exercise again. Just to highlight that we don't mean hopping on a treadmill for 30 minutes. Again, it can be just that nice, low, moderate, comfortable day-to-day movement. So looking to post-bariatric surgery in the immediate and early kind of recovery phase, what we would kind of be encouraging and focusing on would be early mobility and transfers, so trying to regain function and optimise independence, avoiding strain to the surgical site and not exceeding any limitations that have been established by the surgeon. We would address patient physical activity beliefs and values and maybe past experiences with physical activity. We'd encourage slowly resuming physical activity, so typically starting with a walking programme, aiming for about 5 to 10 minute bouts of physical activity prior to discharge. We encourage self-monitoring, so this can be using the Borg scale to guide intensity, which is something I'll chat about in a while, or maybe using something like a step counter. We'd also encourage setting SMART goals and using any kind of available resources, printouts, links to useful video links, which again I will chat through in a little while. So moving on to the medium and long term, so of high importance is to begin resistance work, so strengthening exercises to build lean muscle mass and to improve exercise tolerance and bone health. The patient should also build on cardiovascular training, again to continue to increase exercise tolerance. And then it's also advised to incorporate some flexibility exercises and core stabilisation exercises. So these can be quite nice to do in a group environment, so in like a Pilates or yoga class. So as we've kind of seen from the evidence, there's insufficient physical activity levels in both pre and post bariatric surgery. So why do we think this is? So physical function, of course, has a strong tie to your activity levels and your ability to move. We know moving around is hard when you're living with obesity for a number of reasons. I think this slide might move on without me moving it, so I better get a move on. So yeah, there we go. So first of all, the kilogram weight itself causes extra mechanical energy cost and makes moving around more difficult. And it can make just moving or engaging in routine movement quite hard. People living with obesity also carry a heavy psychological load, so they may have had experiences with weight stigma or shame. This can manifest in low self-worth or self-efficacy, and all these things can be a psychological load, and it can influence an individual's ability to engage in movement, but also impact maybe the value of the physical function to that individual. There are also significant mechanical cardiorespiratory limitations and challenges to those living with obesity that makes the work of breathing harder when you start to move. It's not a very nice experience, and again, maybe a reason for someone to avoid physical activity altogether. So chronic pain is a big one. Again, pre and post surgery, as we heard from Shell's story there. Just going to go back. And pain is something I'll chat about in more detail in the next slide. But it's just important to know that it has a massive influence on movement. And people often hear phrases, particularly in relation to arthritis, like wear and tear. And those kind of phrases can just contribute to that kind of fear avoidance and leading someone to maybe avoid movement. It's important as well to keep in mind other complications that can affect an individual's ability to move, things like type 2 diabetes, sleep apnea, which again is something I know you've heard about from Claire already, and something we'll chat about in more detail on the coming slides. And then also lower limb edema and recurrent cellulitis affects about 20% of our population, and again can be a real barrier for an individual who's trying to engage in just routine movement. And then lastly, how people's expectations and maybe previous experiences with activity and movement. So say, for example, if someone has tried lots of different forms of activity and they haven't achieved the results they were hoping in terms of weight loss, or they've seen, these shows on television that show people engaging in these grueling exercise routines and they get great results. So someone tries that at home and they don't get those results, and maybe they just get pain, and then they start to think, oh, well, what's the point? Exercise is pointless. So we're trying to shift the focus, that the purpose of exercise isn't for weight loss. It's about maintaining function that's being eroded by this disease. So just chatting a little bit more about pain then, as it is such a barrier. It affects about 90% of our patient population here. So you can see low back pain being, I suppose, the most common, and then followed by knee pain. And as we heard from Shell's story, she's still dealing with significant pain issues post-surgery. And studies have shown that weight loss associated with bariatric surgery alone appears to have only a modest effect on MSK impairment and pain. And going back to those kind of phrases that patients often hear, particularly around arthritis, things like wear and tear, bone on bone, or, my joints are crumbling, I've that kind of thing. Again, these words can be really damaging. They're non-factual, and all they do is contribute to that kind of fear avoidance cycle and heightened perception of disability. So, you're not expected to be experts in chronic pain management, but I suppose where you can have a positive impact is not collaborating in that kind of existing fear. So taking the fear away, from movement, and instead encouraging patients that it should be used instead as a strategy to kind of manage pain and maintain function. So again, the kind of language matters, and the words that we use matter. So moving on to sleep then, again, Claire spoke about this, and we know obesity is one of the most important risk factors for obstructive sleep apnea. So sleep disordered breathing is highly prevalent in this population. So just looking at our weight management data here, you can see how the risk increases with increased BMI. And it's estimated around 77% of bariatric surgery patients have sleep apnea. So at present, CPAP, so continuous positive airway pressure, is considered the mainstay of treatment. and it is associated with improved health outcomes. And we know how important good quality sleep is as part of that whole wider weight management puzzle. But it's also important to note, as Claire said, that untreated sleep apnea is associated with greater risk of post-op complications. So it's really important that this is on our radar. Unfortunately, access to a sleep assessment is limited, and often patients aren't assessed unless they're symptomatic. So again, this is where you guys come in, and if you meet patients along their journey towards bariatric surgery, this is something that maybe you can raise with them, and if they haven't been screened for sleep apnea, that you can maybe look at making an onward referral for that. So looking then to the value of physical activity post-surgery, we kind of briefly already spoke about it, but need to address is the value of physical activity post-surgery to elicit more weight loss. So thankfully, we've moved away from this idea of thinking that obesity is a simple energy problem, with that simple solution being eat less and move more. And we know that this is a broken model, and one that doesn't fit any longer, and managing weight is a lot more complex than that. We need to keep that in mind post-bariatric surgery. So as we know, there's huge variability in weight loss post-surgery. There is growing evidence that patients' health behaviours, including physical activity, may play a significant role in weight loss and other post-op outcomes. So this is a retrospective study that looked at weight loss trajectories following bariatric surgery. And it found that there were several demographic and behavioural factors that distinguished between those trajectories. So physical activity, as I said, was one of the behaviours along with eating style. So you can see there those who were on the trajectory to achieve above average weight loss were associated with more changes in their eating style, and they were younger. Those who were low responders to weight loss had less changes in their physical activity levels and were male. So a lot of these factors like age and gender are heavily predefined. And even looking at our health behaviours, a lot of these are genetically predefined as well. So again, it's recognising that not everyone will have the same journey, and we need to recognise that behaviour change is difficult and normalise that, and kind of tailor our behaviour change intervention to that individual. But I suppose it's kind of reasonable to conclude and take away from this that for maintaining positive results, small changes to behaviour around activity and diet are important. So this is another study that looked at weight regain and eating behaviour in physically active and inactive women after 2 years post-bariatric surgery. And what it found was that weight regain was statistically lower in the group that was physically active. So again, just reinforcing the concept that for maintenance of positive results after surgery, it is important to maintain a healthy lifestyle, and that includes diet and physical activity and practice. So as we know, the long-term efficacy of bariatric surgery is variable. It's not a metabolic remedy for all. We know about 10 to 30% will experience suboptimal weight loss, and around 20 to 30% will experience a relapse in type 2 diabetes after 5 years. So it's plausible that exercise could be particularly effective at eliciting additional weight loss in that kind of patient population. So this study shows the potential mechanisms by which exercise can impart additional benefits for this population. So exercise or physical activity can increase energy expenditure, and that can help with weight maintenance and preventing weight regain. And then also with exercise and physical activity, you have preserved muscle mass and improved insulin sensitivity, which prevents diabetes relapse. So this is a study then just looking more closely at how physical activity or the impact it has on our metabolic health post-surgery. So 128 patients post-bypass were divided into 2 interventions. So the first group underwent a 6-month semi-supervised moderate exercise protocol, and then the second group was the health education control. And what it found was that there was greater improvements in insulin sensitivity, glucose effectiveness and cardiorespiratory fitness in the exercise group compared with the sedentary group during similar weight loss. So going back to that original question, and I suppose it's maybe we need to, I suppose, change that question, and is this even a question that we should be asking? We've seen there the benefits of physical activity independent of weight loss, and as I said before, our aim is to restore normal movement and function and prevent it from being eroded by the disease. So again, we focus not on weight loss but on health gains, and because of the little impact physical activity has on weight loss alone, there's often, I suppose, a lack of perceived health benefits. So again, it's getting that message across to patients that there are so many other benefits of physical activity post surgery. So we've already spoken about the impact on metabolic health, so reducing inflammation and insulin resistance. Physical activity after surgery is also associated with less premature mortality, better quality of life, has a positive effect on mental health and improved sleep. And then it's also linked to an improvement in cardiorespiratory endurance capacity and muscle function. So that brings us on then to sarcopenic obesity. So sarcopenic obesity is a clinical and functional condition characterised by the coexistence of obesity, which is excess fat mass, and sarcopenia, which is low muscle mass and function. So both sarcopenia and obesity have a multifactorial etiology and increased prevalence with ageing. However, sarcopenic obesity can occur at any life stage. They share common pathophysiological mechanisms, including chronic inflammation and insulin resistance, and also may synergistically enhance one another. It's a serious health concern and one that is associated with increased adverse health outcomes, such as increased physical disability, frailty, and mortality. So having a look then at the value of muscle and the role it plays. So we know muscle plays a role in structural function in terms of movement and strength and maintaining posture and balance, but it's also a metabolic endocrine organ, and it plays a central role in whole body protein metabolism. So it plays a role in maintaining protein synthesis in vital tissues and organs, and it's also important for maintaining glucose levels. So what happens then when we lose muscle, such as in sarcopenia? So with that muscle weakness and loss of muscle mass, we get that decline in physical activity, which leads to increased falls, increased fractures, reduced strength. But then there's also those metabolic consequences. So reduced energy expenditure and increased insulin resistance. And then on the other side of things, you have obesity with increases in abdominal fat. This further increases insulin resistance. And then there's a host of mediators which come into effect, which also impact sarcopenia. And it is when sarcopenia and obesity are combined that's when you have increased cardiometabolic disease, increased mortality, and increased physical disability. So why is this something that we need to be concerned about, particularly post-bariatric surgery? Despite the known benefits of bariatric surgery for our metabolic health, severe energy and protein restriction may occur. So along with losing body fat, fat-free mass might also be lost. So there's a high risk post-bariatric surgery. Prevalence has been difficult to accurately estimate. This is due to the fact that there has been a lack of universally recognised definition and also diagnostic criteria. But it has been kind of estimated that the prevalence in post-bariatric surgery patients is around 7.9 to 23%. And as a result of this, these patients require close monitoring post-bariatric surgery. So this was an observational study done in 2021 of patients that underwent bariatric surgery. And what it found was that 2 years post-surgery, fat-free mass continued to drop, but fat started to increase. So I mentioned before the standardisation of the definition and diagnostics has been a major constraint to the literature around sarcopenic obesity. In May this year, the European Society for Clinical Nutrition and Metabolism and EASO, the European Association for the Study of Obesity, launched an initiative to reach expert consensus on a definition and diagnosis or diagnostic criteria. So they recommended sarcopenic obesity should always be considered in at-risk individuals who screen positive for co-occurring elevated BMI or waist circumference and markers of low skeletal muscle mass and function. So diagnosis to confirm or reject sarcopenic obesity should always follow a positive screening result. So this should include initially assessment of muscle function, so through a hand grip dynamometer or the 5 times sit to stand test. And if low skeletal muscle function parameters are detected, then continue with assessment of body composition. So the go-to would be DEXA or else BIA as an alternative second choice, or also CT. So exercise is an effective strategy to improve body composition parameters in both sarcopenia and obesity. So as a strategy to counteract sarcopenic obesity makes sense. Studies have found exercise, particularly resistant exercise, can help to attenuate muscle mass loss in patients post-surgery. And strength or resistance training has been shown to increase muscle mass, muscle strength, and protein synthesis. So exercise will kind of complement nutrition, which is also working to counteract obesity and sarcopenia. So again, it's really important that you guys feel comfortable, chatting with patients about resistance exercises, and that's kind of part of your repertoire. So looking then at some ways or maybe some helpful tips and approaches that you might take when you're engaging in discussion around physical activity with your patients. So for many people, understandably, as we went through the barriers and how that impacts on movement, the thoughts of increasing activity levels can be really overwhelming. So advice should be more about how to incorporate movement into everyday life. And as we said, we know that low to moderate activity is beneficial. So working with the patient to establish maybe where movement and activity can fit into their daily routine. So whether it be at home through reducing screen time, adding in movement breaks, doing housework, or on their commute, so by parking that little bit further away or taking breaks in the journey, at school or work, taking movement breaks using the stairs instead of lifts, or trying to get a standing desk. And then of course you have your leisure activities. So we typically would be advising moving around every 30 minutes. So just some strategies then that you can maybe take forward to help enhance physical activity uptake or maintenance. So helping your patient to again understand that exercise isn't about hardship. We're looking for that enjoyment factor, something they enjoy doing. It's more likely they will adhere to that than something that they don't enjoy. And again, some people enjoy that kind of social component, so maybe exploring moving around with a family member or looking at joining a group. relaying that message of kind of starting slowly and gradually increasing, and that idea that all those little bits kind of add up. It doesn't need to be one single long bout, and that can be a much more effective way of managing the barriers to physical activity. Again, we would advise SMART goals, and then that idea of self-monitoring. Some people prefer to use like an old-fashioned diary, keep track of their minutes they're active, or on the other side of things, maybe monitor their sedentary activity. Other people will find the wearable devices, Fitbits and things like that, quite helpful, and they can be really helpful with adherence. Again, there's kind of those messages out there that we need to be getting a certain amount of steps, so that 10,000 is often thrown around a lot. But it's important to note that, again, every patient will have their own individual unique step number that's kind of unique to them. So this is the Borg scale that I mentioned earlier. So it's a really nice resource, especially when patients ask, how hard should I be working? So we're aiming to be somewhere within that kind of green area. We never want to be up around the red. So you're aiming for kind of a slight challenge where you might maybe feel your heart rate going up a bit, feeling slightly puffed, working a little bit hard, but still in control, still comfortable. So just, I suppose, some resources that you maybe could take forward. So the HSE have a really nice page on YouTube. You might have seen it, the HSE Health and Wellbeing. And recently they've uploaded some really nice videos done by a community physiotherapist. So if you have someone that maybe is looking to start a bit of resistance exercises, she's done out nice videos. So there's one that's 45 minutes, but she's also done a nice kind of shorter 10-minute one. There's also other videos up there, kind of chair yoga and general aerobic exercises as well. And then you're all probably familiar with the ICPO, and we run a monthly movement club with them. And again, the focus in those classes is just about maybe moving parts of their body that maybe haven't moved today. It's not about burning calories or kind of, pushing yourself to that place where sometimes we feel we need to go to get benefit from exercise. So again, I suppose that the main message to kind of take away is that everyone is individual, everyone will have their own barriers, and that's something that you need to keep in mind when you are engaging in a discussion with physical activity, or discussion about physical activity with your patients, and that the best exercise program for them is one that they will do and will be able to do comfortably. And thank you. Any questions?
I've raised a bit of that.
Yeah.
It's just, I know we're kind of talking a lot about kind of challenges as well. Pain can be one of the biggest ones. Would you know of any resources in relation to, say, like chair exercise and things you could do while seated?
Yeah, and again, so that popping onto that website, they do really nice chair exercises as well. So I would highly recommend, that's just the chair yoga one, but they do general seated exercises as well, kind of at that kind of nice low intensity, and I've kind of started recently sharing them with patients, and the response has been, really, really quite good. And again, it takes away that fear of maybe some people don't like going to classes, and doing it in kind of the comfort of their own home is a nice option for them, and especially coming into the winter as well. It's really nice. So there, I would definitely kind of recommend popping onto that page.